Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about rheumatoid arthritis. Rheumatoid arthritis is a very common medical problem. In the world, there are 1.40 million people who suffer from rheumatoid arthritis. In this country, is about 2.2 million thereabout. It is more common in women than men. When I left off last week, I was talking about the different medications that I use to treat rheumatoid arthritis, and I told my little personal story about methotrexate, how it happened and how it was from that thing that I did via DNA recombinant technique. People were able to develop all this stuff you see on television, all the all the biologic. I have nothing other than that to do with them. I didn't create them, but I started the whole revolution as it related to methotrexate because I did the first research at Brookdale Hospital. That shows that methotrexate there's prevented development of antibodies, and the rest is history. Now, I have a list of medication that are being used throughout the world to treat rheumatoid arthritis, and I'll list them for you. The list is quite long, okay? We got to talk about aspirin, endocin, Motrin, naproxen, Clinol, Feldane, Depro, Relafin, Anaprox, Celebrex, methotrexate, Arava, Minocin, steroid, Imuran, Cytoxin, Roentia, Kineret, Humira, Rituxan, and one of the most recent biologic approved by the FDA, of course, is Rinvoq. Now, one of the medication, of course, that I want to use to explain to you really the mechanism that causing this whole problem with rheumatoid arthritis. Let's take the example of Rituxan, okay? Rituxan is basically a medication that was first created to treat Hodgkin lymphoma years and years ago. And it turns out that it is good to treat a whole bunch of other stuff. In fact, it is hardly ever used in this country anymore to treat Hodgkin lymphoma, but it's being used all over the place for a whole host of other things, including rheumatoid arthritis. Now, the situation that causes the inflammation that then result with all the destructions and the pain and the destruction of rheumatoid arthritis, it's an inflammatory process. Now we know the inflammatory process occurs because there's a substance that are circulating in the body called B20s. And of course, we have B lymphocyte. The B20s it's a protein type material. They find themselves on the surface of the B lymphocyte. That then activate the B lymphocyte to create the destruction that is occurring, resulting with all the pain and the swelling and all the whole other issues involving with rheumatoid arthritis. Now, when one uses, let's say, for instance, Rituxan, which is basically, I told you, is a very common medication that's being used for a whole host of other stuff. I have many patients myself that I'm treating with Rituxan, and it works. And the reason why I'm taking the time basically to explain that is because there are many folks who listen to this show that are medical students and physicians and nurse practitioners, etc. So I don't want to be too academic, but I like to get into the basic to explain to you what is the CD20s are. The CD20s are bad little guys. They're the one. We all need the lymphocyte, but the lymphocyte themselves won't cause the problem. It's when the CD20s are attached to the body of the B lymphocyte. That's when they become overactivated and they cause the inflammation to occur. And when that happens, it creates a whole host of problems. Whole host of problems I have discussed in the last previous 3 shows that it relate to rheumatoid arthritis. Therefore, then, Rituxan is super expensive, by the way. It's not something that you're going to use very often to treat rheumatoid arthritis. Is a last resort because it's super expensive I doubt very much if the insurance companies will even approve that, because you have to try so many other things. Now, but that's medication itself. If you take the example of retoxin, it shows you how all the other stuff work to try to decrease the swelling, the pain, and effusion, the destruction of the joint that occur in rheumatoid arthritis. It's a very, very bad disease. On top of that, it is a systemic problem, systemic disease. Systemic disease. All organ in the human body can be affected to one degree or another, because if one suffers from rheumatoid arthritis at one point or another, because it is an autoimmune slash inflammatory disease. That's where the retoxin plays a major role, because retoxin works to interfere with the autoimmune part of it. It also works to interfere with the inflammatory part of it. Now, I talked about aspirin last week because it's the most common medication used across the world, because it's the cheapest. It's a very good medication. Aspirin is an anti-inflammatory medication. It's an anti-pain. It's an anti-fever medication. It's fantastic. Now, let's say for the sake of argument, someone is suffering from rheumatoid arthritis, and you need to put them on, let's say, an NSAID, but the person is having a stomach problem, which is so common, because you have to understand, when somebody in the population of folks that are 60 years old and older, close to 70% of them have GERD. And GERD is a very common problem. It causes a lot of acid reflux, which is what it is, can cause irritation of the stomach, etc. And they need the medication. So how do you go about it? Well, there's a medication out there called Cytoxin. I'll explain to you how Cytoxin works, that you could use Cytoxin when you get putting somebody on an NSAID or aspirin or whatever, because, and we have a lot of people that are on aspirin for a lot of reasons. If they're on aspirin already, and you have difficulty really put them on an NSAID, because the two of them will be too much for the stomach to tolerate. And they're on the aspirin for different reasons, to prevent cardiovascular disease, what have you. Now, here's the deal. If you use Cytoxin, not Cytoxin, I mean Cytotex, not Cytoxin, I'm saying Cytotex. Cytotex has 3 ways in which it allows you to use an NSAID or aspirin or Celebrex or something like that, because first of all, it increases the pH of the stomach. Yeah, the acid that is in the stomach, the Cytotex increases the pH. That's one good thing. It also, the Cytotex increases mucus production that buffers the stomach, so as you could use it, prevent the aspirin from eroding the wall of the stomach. And on top of that, it also increases blood flow to the stomach. So Cytotex increases the pH, elevates the pH. The more acidic the stuff in your stomach is, the more likely you're going to have problems. It increases that. It increases the production of mucus that buffers it, and it also increases blood flow. So the more blood flow you have going to the stomach, the less likely you're going to have an erosion, ulcer, because one of the most common problems associated with all these NSAID, the aspirin, the Celebrex, of course, is ulcer formation, erosion, gastritis, which it can lead to ulcer. Now you have to understand, I'm going to tell you something, you couldn't believe it, but it's true. When you get a PPI, such as, the PPIs are all over the place. Omeprazole is one example. They're great medication, but this medication will not prevent you from having an ulcer. If you have an ulcer, they will relieve the symptom. They will also help to heal the ulcer, but they don't prevent an ulcer. How about that? The only medication that I'm aware of in this country, probably across the world, that will actually prevent the development of an ulcer is Cytotex. How about that? So many of us who understand this concept, and there's so many brilliant doctors out there who clearly understand this stuff, so they will add the Cytotex to, they give it to individuals who are taking aspirin or taking NSAID because they have pain, swelling, effusion, whatever. So you could use the cytotext, and it allows you, it prevents. So in other words, cytotext is the only one of this medication that's actually prevent an ulcer. The others only relieve the symptom of an ulcer, they heal the ulcer. You understand that? So the PPI, they're all over the place. Even they just simply do not prevent ulcer. I wanted to make that point very clear. We got to be very careful with cytotext as well, because you'll be getting the warning. Because across the part of the world, other than this country, cytotext is used to induce abortion. So if you're going to prescribe some cytotext for someone, you have to make sure they don't have women of childbearing age in the house, and if they do, you have got to make sure they don't get their hands on the cytotext. That's the reality of it. I'm saying this, I'm not encouraging anybody to do anything inappropriate. I'm just telling you, to be complete, you got to be very careful with that. So therefore then, that's one aspect of the treatment of rheumatoid arthritis, medications. We talked about steroid last week. However, there are a whole host of other problems that can cause you to require orthopedic help. Why? Because the bone is going to wind up being destroyed, deformed. I mean, the deformation is incredible. It is so bad in the hand and the fingers that a lot of folks have to give up a profession that they were involved with that needed the use of their hand regularly to do the work. They cannot do it. And it is the chronic, recurrent, inflammatory processes that cause the bone to become destroyed. Now, so that's one aspect of it. So what do you do then? Well, first of all, you will send the patient to a rheumatologist. There are excellent rheumatologists out there. That's what they do for a living. They take care of rheumatological problem, and rheumatoid arthritis happens to be one of them. The reason why you will need the help of a rheumatologist, because the rheumatologist will be able to figure out if there are other rheumatological problems that may be associated with the rheumatoid arthritis. Just because somebody presents with rheumatoid arthritis, that may not be the only rheumatological problem they have. So that's a very important point. People like myself, who I'm a general internist, and other general internists show they can diagnose rheumatoid arthritis. They are diagnosing it, they are treating it. But you really have to be very careful. If you're not in academia, where you're forced to learn this stuff and teach it, you may not be up to date on the fact that there are many other associated rheumatological problems that may be associated with rheumatoid arthritis that you might miss. And the patients continue to have symptoms because you forget why. Well, because there are other conditions. If you have one rheumatological problem and you live long enough, be certain you're going to have a second, probably a third. And as I continue to lead the series on rheumatoid arthritis, I will show you examples with an S of other conditions that may be associated with the rheumatoid arthritis. That may be the first one that you present with, or the other way around. You may have another rheumatological problem, and out of the blue, suddenly you're starting having rheumatoid arthritic symptom as well. This stuff is complex, very complicated, and as I said, that's why there's so many excellent rheumatologists out there, and there's really no need for me to just, I mean, I take care of my own patients, but I'm a professor, I teach this stuff, so there's no need for me to refer patients to rheumatologists. What they're going to do that I don't know how to do, forget about that. But my situation is different. Suffice it to say also, you're going to need a orthopedic doctor, because you wind up doing x-rays. The x-rays may begin to show the deformities, the arthritic changes, but you may wind up needing a CAT scan. You may wind up needing an MRI. All these three things you may need at one point or another if you're suffering from this condition. And then, of course, that's where the orthopedic doctor comes in. Frequently, some joint have to be replaced, or some joint has to be treated locally with injection of steroid, etc., by the orthopedic doctor or the rheumatologist in some cases. So this is why you have to be, as part of your evaluation, you're going to reach the point where you have to do x-rays, you may have to do CAT scan, and you may have to do MRI. Okay, and the basic thing that is really going to block all this stuff I'm talking about is the monoclonal antibodies. Okay, like Rituxan and methotrexate works somewhat differently, but the basic notion is the same. So let's say somebody present with an effusion in the knee, okay, and they're suffering from rheumatoid arthritis. So what are you going to do? Well, they go to the emergency room, and or they shoot them in the office. You're going to refer them to either rheumatologist or orthopedic. They're going to have to tap the knee to suck up the effusion because it's sore. It's the thing is all swollen and it's painful. Now you got to be very careful. If you're going to remove the fluid, i.e. the effusion, wherever you find it, it could be the elbow, could be the knee, could be the ankle or whatever, because it's uncomfortable and painful. But you got to do something with the fluid because you can't be certain that the fluid is only the result of the rheumatoid arthritis. It may be something else. Patient may have gout on top of that, on top of the rheumatoid arthritis. The patient may have an infection. So you don't want to mess with that. So you really have to know what, first you're going to remove the fluid. The more fluid you remove after you clean the area up with a little bit of anesthesia there, that will help to relieve the pain to begin with. Then what do you do with the fluid? The fluid has to be sent to the lab. Has to be separated in 3 separate parts. The part goes to the hematology lab, a part goes to the chemistry lab, and a part goes to the microbiology lab. And I'll tell you what you do with each. Let's take the part that goes to the hematology lab first, because that's the quickest to get. What are you looking for? Well, you're looking for white blood cells. How many white blood cells are there in this fluid that you send to the hematology lab? And then you're going to make a smear of a little bit of it, and you're going to stain it with Gram Gimsa to see the characteristic of the cell, because you'll be careful. There may be an infection there, and you don't have time to wait for the microbiology report to come in. You have to act right away. So that's the main reason why you really send it to the hematology lab to check it out, make sure the fluid doesn't have too many white blood cells, and so on and so forth. And you smear it out to do a differential on it and so on. Then you send one tube to the chemistry lab. That's crucial. When you get to the chemistry lab, there are ways we can tell if there's crystal there that are due to gout. We could tell that under the microscope. Then you're going to evaluate the protein level in the fluid. You're going to evaluate the glucose level in the fluid. That is key. If it is just an inflammation, then the protein would be high and the sugar would be normal. You understand that? If it's just an inflammation, the protein in the fluid would be high, the glucose would be normal. However, if it's an infection that's in the fluid that you receive, is the key. The protein will still be high, but guess what? The glucose will be very low. That's key, because the patient is waiting in the emergency room. If you have an infection, you don't have time to wait. If the glucose is low, because we know the normal glucose, what should be in the fluid. If it's low, that tells you there's an infection. The bacteria is using the glucose to survive. Therefore, there's an infection. And so that's the main reason why you send it to the chemistry lab. And of course, you look for crystal to see if there's gout, pseudo-gout or gout or whatever. And of course, you would have done a uric acid. Anyway, don't be fooled. I know I shouldn't be telling you this stuff, but I will. I will. Just because somebody's uric acid is normal does not mean they don't have an acute gout effusion, okay? You say, well, how come? Well, because academically speaking, the uric acid is piled up in the effusion. And that's why you see the crystal, and the serum uric acid may be perfectly normal, and yet you still have a gouty effusion because it's not in the circulation, but it's piling up in the, how about that? So be careful, okay? In the meantime, you would have taken the patient's symptom, you know, he or she had gout before, blah, 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 the rest of it. And now you go to the microbiology lab. What do you do there? Well, first thing you're going to culture it. Yeah, that takes 72 hours, okay? However, you're going to do a staining. If you do the stain right there in the lab, in the microbiology, you could actually see bacteria under the microscope. How about that? You could see it right away. You could actually see gram positive, you could see gram negative, you could see cocci, you could see all that under the microscope in a few minutes. So right away you call the emergency room. Oh my goodness, there's bacteria there. We don't know which it is, but we know it is a cocci, you know, or it's a rod. Then right away the doctor knows to go right in and start treating this patient with an IV antibiotic. Immediately admit the patient. When you have a joint that is infected, you don't treat it on the outside. Because if you miss that infection, within 48 hours, this joint is going to be destroyed permanently. So this is how you would handle this thing. Of course, you would have done blood culture, and sometimes, believe it or not, it's not the rheumatoid arthritis that's causing the problem. Is the patient is bacteremic, has an infection in his or her circulation, and some of it finds its way into the deformed joint, because the joint is so deformed, things can't pass through smoothly, and you got an accumulation. Just because, and sometimes the patient, you could have something with your heart. You could have an infection in your heart, and the heart is pumping. The heart can pump the bacteria all the way to the joint. So when you see that joint is infected, you are required to evaluate the patient for sepsis / bacteremia. You are required to evaluate the patient heart valve to make sure the valves are okay, that they're not pumping bacterial material into the joint. I mean, this stuff is complicated, but I want you to know there's nothing simple about clinical medicine. One thing, you have to know how to interpret it and how it can lead to something else. So rheumatoid arthritis, therefore, is a very, very serious medical problem, very, very complicated, and you may wind up having to send the patient to the orthopedic. Sometimes a joint has to be removed. So that's the primary problem. Then you got a secondary problem, which I will get into in more detail in the next show because we won't have enough time. Suffice it to say, you have a primary problem. You cannot have rheumatoid arthritis and don't be anemic because of it. How about that? Okay, you cannot have rheumatoid arthritis, let me repeat that, and don't become anemic because of it. And I'll give you a little taste of why that is. Well, you have a chronic inflammation. That chronic inflammation itself is an infection. That's not an infection, but that inflammatory process is going to spill stuff into your bloodstream that's going to prevent you from properly making red blood cells. How about that? That's exactly correct. Because the transferrin receptors are circulating in the bloodstream, they're waiting to grab onto iron molecule to take it into the bone marrow. But if you have a chronic inflammation, that chronic inflammation is going to cause you to have a chronic anemia of chronic inflammatory disease, which means that you cannot use the iron that's in your system. It's piling up because the inflammatory process is blocking the ability of the transferrin receptors to grab onto the iron molecule to take it into the bone marrow to be incorporated in baby red blood cell. How about that? So you cannot have rheumatoid arthritis without having anemia of chronic inflammatory diseases, period. So you have to understand that. So that compounds the problem. That's making the situation even worse. And you got the iron is piling up, and because you can't use it, it's going to pile up. So wherever the iron is piling up, that itself causes a secondary inflammatory process. You say, well, how so? Well, once the iron is piling up, the iron must degrade Wherever it is piling up, and okay, where it is piling up, it's got to be degraded. Well, if the iron is being degraded, that process then going to cause the development of free radical, and the free radical then set up the whole cascade of an inflammatory process on its own. You already have something that you're dealing with, which is rheumatoid arthritis, that's inflammatory, autoimmune in nature. Then you got on top of it a secondary anemia, and then you have a third problem, which is the fact that you are having this inflammation taking place because of the iron deposit. It's a multifactorial system. And you have to, nothing is simple. Let me tell you, anybody who tells you something is simple in the field of clinical medicine, run away from them. They don't know what they're talking about. Okay, this stuff is complicated, but you have to, how you joint the thing together. And then, of course, that's the reason why when people who have rheumatoid arthritis are getting ready to go to the OR to have a joint removed, because they're anemic, they have that type of anemia. Almost always, if the anemia is severe, the orthopedic doctor will have made an arrangement for this person to have to be given Procreate or Epogen months before the surgery to allow them to improve their anemia, so that they can then not only get anesthesia, they can also have their own blood taken away from them to save in case they need blood transfusion. This stuff is complex. Let me tell you, it is not simple. And next week, in the next show, I'll get into more detail how that is done and why it's being done, and with the process, the mechanism on how that's done. And also the whole concept of the joint has to be given injection of steroids sometime to decrease the inflammation. How important that is, also how dangerous that can be. How about that? Can be extremely dangerous, okay? You could destroy the joint if you give too much steroid too often and too many, okay? As important as the steroid is locally, you could actually do more harm than good. And I will explain to you the mechanism through which that can occur. This is serious business. Listen, this book came out a few months ago. I just wanted to introduce it to you. The Best of Medical Oncology and Clinical Hematology. That's my latest book. Came out about in the beginning of the year. Take a look at it. Also, I wanted to make a few minutes to again encourage individuals. We are in the middle of this pandemic, the COVID-19 pandemic. Please listen carefully. Wear a mask. If you must go to the supermarket or somewhere, put the gloves on. Keep your distance. So social distances, wearing the mask, and using the glove. Those are very important things to do. Listen, until I see you again, this is Dr. Alcena saying so long and bye-bye.